Okay, students, we are getting ready to look at chapter 10, which is the last chapter of the kinesiology and biomechanics unit. And we, or you, me, I, all of us have been working on the names of the bones and the landmarks and the joints and the language around the joints, and then the individual muscles that move the joints. And now it's time to take that information and put it into perspective on how we actually function in our musculoskeletal system. That's what biomechanics are. So let's go. As usual, here is our textbook. And we are in chapter 10. And I will close the table of contents here. A lot of this is going to feel familiar because we have been talking about it already. And then this chapter also gives you a lot of information related to various assessment procedures related to massage. For example, here, walking and gait or posture, and what's postural stabilization. We also talk more about the kinetic chain, those muscle synergistic relationships, activation sequences, and then a really beneficial segment right here on assessment based on biomechanics. Again, not typically found in a generalized anatomy and physiology book, but very helpful in learning how to incorporate the various biomechanical concepts into our daily massage with our clients, and then the various pathological conditions. All right, chapter objectives, key terms, learning how to learn, definitions on kinesiology. So kinesiology is the study of body movement. When we're learning the names of the bones and the names of the joints and the names of the muscles, that's a nomenclature. Kinesiology itself is the movement of the body, and the bones and joints and muscles, along with the nervous system and the circulatory system, etc., are what's involved. And it does involve a lot of anatomy and physiology. So biomechanics is a larger field than kinesiology. Kinesiology includes the biomechanics of motion, and then combined with the rest of the system's involvement with it. Biomechanics is also an important aspect for us in how we use our own body. It is part of the study that would relate to our foot stance and the ergonomics part of it with the size of the room and the type of shoes we wear. And so there hasn't been a ton of study in the massage world about appropriate biomechanics, but the Massage Therapy Foundation has been engaged in study. And so in Fundamentals of Therapeutic Massage, the concepts we present there for you are based on solid biomechanical and ergonomic principles. So here's our overview and language structure of biomechanics. We've already talked about force. Massage introduces a force stress strain application. So repetition in a little bit different context here. We also have the terms here that about what happens to tissue when it is stressed. So it's loaded and then the deformation happens. That's the stress. So elastic, viscous, viscoelastic, brittle, and that gives you examples here, ductile and plastic. So we never actually see the stress. What happens is the stress deforms the tissue. This is the strain on the tissue, and the strain is defined as the amount of deformation tissues experience compared to their original size and shape. And then too much strain is what causes an injury. So if we look at a contusion, a bruise, that's a compression injury to soft tissue. It presses tissues together. And so how much pressure into that structure can occur before tissue damage is identified or results. The same with a muscle strain where the muscle has elongated so much and quickly usually that the tissues in the longitudinal or tension force arena, they can't respond and then they fray and break. So here are some massage examples to this. Soft tissue is viscoelastic. Massage application gliding with moderate pressure results in tissue loaded with combined compressive stress and tension stress. And then it creates a longitudinal tensional strain, and the outcome is temporary elongation of the tissue. And so here's some injury examples. Soft tissue is viscoelastic. All right. Action causing injury, being hit by a ball, results in tissue loaded with compressive stress, creates compressional linear strain, and the outcome is contusion or a bruise. Bone is brittle. So action causing the injury is falling downstairs, results in tissue loaded with combined compressive stress, tension stress, and shear stress, creates longitudinal tension, compressional, and shear strain, and the outcome is a broken bone. So I think this is really helpful in this box. It's really helpful in kind of conceptualizing what happens when mechanical loads are applied to the body, both therapeutically as well as in causing injury. So when you're learning about massage, you learn about the various types of tissue loads and compression and shear and bend and that sort of thing. We looked at that in chapter 8, I believe, with the ELAP terminology. But you can modify all of that. You can create an infinite number of applications and results by shifting around the amount of pressure or the direction, or so a gliding stroke would create a tensional strain. It loads the tissue, pulls the tissue apart, and we can increase the magnitude of that by, really aggressively separating that tissue. I don't know why we would want to do that. Or we can press down harder and get into deeper tissue layers with that. So pressure is an interesting aspect of this for massage therapy delivery, as well as the experience of massage. And uh, it's the amount of force on a specific area. So the method called compression generates a compressive load. Then the amount of pressure used during massage depends on the variations in the compressive load and the size of the surface where the load is applied. So you can read through this yourself and you can get an idea of all these factors here and how they influence the tissue's response to being loaded through mechanical force. And stop and think about how we would want to load tissue sufficiently to get a response out of a mechanical response with the tissue as well as a neuroendocrine response, but not so much to cause any kind of an injury. Okay. This is a box that's really important. It's you'll hear us here talk about leaning uphill, but it has to do with vectors of force, what the direction and how it's going into a structured tissues. So if I massage down the hill, my pressure is into this structure, but another piece of that is just going off into the air. Whereas if I go the other direction, I'm getting pressure in through both areas in through here. This visual always tickles me. It's really good, but the artists that drew this, the feet are very weird. Okay, mentoring tip. Here we go. Mechanical advantage and disadvantage has to do with when you are providing a force around a jointed area, how close or how far are you away from the joint? And the further away you are from it, the more mechanical advantage you're going to have. A practical application of this would be muscle testing. So when we are going to, let's say in this example here, we are looking to assess for the strength of the quadricep muscle for knee extension. So we've got the muscle activated with the muscle starting to extend the knee, and then two positions that the therapist is going to push down. When we do muscle testing to see, okay, now can the quadricep do that? We want to have a little bit of mechanical advantage there. So we would go to the distal end of the bone here rather than the proximal end. And we don't have to apply a lot of force to then challenge the integrity of that muscle and joint function. Whereas if we applied that pressure up through here, the structures around the joint, the muscle attachments are going to be, we would have to press very hard to get a change here, and that doesn't give us accurate information. We also have a variety of levers here, first class, second class, third class. Most of the joint structures in the body are third class levers. And they are situated so there's always a little bit of a mechanical advantage, but it does permit rapid movement of a joint with little shortening of the muscle. We've already talked about balance, equilibrium, and stability, but as a review, you can take a look here. And we also talked about the importance of stability, the relationship of stability and mobility. So in order for us to walk, we have to have equilibrium, and we have to have stability, and we have to have mobility. We have to have all of that. We have to be able to efficiently move our center of gravity, and reestablish this equilibrium and stability. Walking is a very interesting concept. So these are the various balance principles. And one of the assessments that you can do for checking to see how well a person's going to be able to walk is to see if they can stand on one foot. If they can't stand very well on one foot, they're not going to have the equilibrium needed to be able to transfer the weight from one foot to the other as we move forward in gait. Okay. Then we have our posture and our postural muscles. That they are about holding the upright position. The arms are not necessarily involved in posture so much, but they absolutely are involved in gait as a counterbalance. So, again, we're standing on 2 feet. This is the biomechanical struggle as well as the strategies to do that. If you look at anything else that holds an upright position, it's got a broad base. It takes, if you're going to try to bounce on a stool, sit on a stool, it's got to have at least 3 legs. I often think of a kangaroo with a long tail, and that's the 3rd leg that allows an upright position and the ability to move forward. So we have all these segments that have to balance, and it's the postural muscles that do that. And if you recall back in muscle fiber type, back in chapter 9, we had fast twitch fibers and slow twitch, and muscles that could hold a contraction for a very long time and others that didn't. And postural muscles need to be able to hold a contraction for a long time. So the fiber type is constructed, those muscles have that. But they also typically are shorter muscles, and they tend to not function so much on the sagittal plane. They do, but it's more of this diagonal frontal plane movement that keeps us upright and balanced. So this is another figure of areas where we have movement in multiple planes. So the atlas axis area allows us to move into flexion, extension, rotation, lateral flexion. Here at the thoracic vertebrae, we can get movement at the lower end of the cervical area. So instead of just movement of the head, we can get a variety of movements just above this segment. The torso itself has some rotation to it, but it doesn't have a lot of adduction, abduction, or rotation. A little bit at the spine. The arms are able to move quite freely. So they're not necessarily part of these movement segments related to posture. Down here, when we get to the lumbar area, the area of the lumbar and then the hips, that is where the flexion and extension occurs at the torso. And then just like with the shoulders, there's movement in the limb segments, hips, knees, and ankles. The difference is the hands are almost always open at the distal end. So they're in an open kinematic chain, and the joints are able to function independently. When we are walking, one foot is on the ground, so that leg is going to be in a closed kinematic chain. But the foot that's lifted and moving us forward, the leg that is lifted and moving us forward, that's in an open chain. And as soon as that foot lands and we get ready to take another step, this switches back and forth and back and forth. These segments right through here are areas that we can visually look at for levels of symmetry. Now, nobody is 100% symmetrical, but this gives us an idea. If there's a lot of asymmetry from one side to the other, it's going to compromise efficient movement. So here are our markers when we look at the lateral view, the anterior view, and the posterior view. There's some more statements related to postural stabilization, then the sitting, standing, bending biomechanics. And then this all becomes assessment. You should be able to sit and stand without using your arms to motivate you forward. If you are needing to reach forward, or you're pushing your hands into your legs to help motivate you up, that would give us a clue that the person is got some struggles in how they are maintaining balance, postural stability, equilibrium, etc. And then here is our gait cycle, which I've already mentioned. And this figure right here gives you the various pieces of that. So you've got your heel strike, your flat foot, the mid stance, and so forth. It's worth it to spend some time with that and walk while you're doing it. And then here's components of the stance phase, and then this shows you the counterbalancing of the arm swing. So right or left leg is coordinated with the opposite arm. So stance, and then we've got our swing. That's where we actually motivate forward. And here's the summary. This is going to start to talk to you more about what's called the kinetic chain. A piece of that are those opened and closed kinematic chains, but this is a little more expansive on this. This includes the fascial muscle interactions and the neurological contralateral, ipsilateral, reflex arcs. And so this is a very functional concept here. So it's the myofascial system, the nervous system, joints, sensory motor integration, and neuromuscular control. This is all of it that works together. This is a reminder of the sensory function, the integrative function, and the motor function. This is nervous system. And the tension length relationship becomes a player in through here. The concept of a one-jointed muscle and a two-jointed muscle structures that cross two joints or go from a joint onto the torso, and how that can be described as an inner or local unit if it crosses one joint. It gives you muscles that do that. And then global units where there tends to be a The joints tend to, or the muscles and structures tend to cross two joints and interact with a more complex movement that involves more joints than just one local area. This schematic here gives you just a little bit idea of those types of interactions. Another term that you will see for this are slings or chains. There's been a lot of study on this. It's theoretical. It's used a lot in athletic performance and rehabilitation. So here are your major global muscles. And then we have tissues that cross transverse in the body. They're called diaphragms. And this is where a lot of forces cross and interact with each other. So previously I had mentioned this idea of muscle motor synergistic relationships, muscle firing patterns, activation sequence. This is a string of terms that basically means the same thing, but it's how functional muscle units crosstalk to each other in order to produce a multi-jointed uh, uh, movement that has there's a coordination to it. It doesn't look disjointed or disconnected. So this is where the idea of prime movers, the main movers, stabilizers, and synergists come in. So stabilizers are going to isolate the pull of the muscle into a particular jointed function, and synergists are helpers. So here's another way to describe the same concept. And this is starting to be a little advanced. I feel that it's very important for a student to have an understanding of this. It's not likely that this will be tested on the NBLEX exam, but you really don't understand how the whole body works together if you don't at least have a beginning exposure to these concepts. Okay, now we're going to turn this into an assessment, series of assessment activities. So I'm, again, just like I did with the muscles, I'm not going to go through every single one of these, but I want to show you how to use the book to learn. So there is a basic plan here on efficient biomechanical movement, and then potentially reestablishing and supporting effective movement if it's gotten out of whack or something. If you take a fall, if you fall, or you trip, all of these things come into play to try to get you reoriented, get your vision back on the horizontal plane, get your vestibular system set up, coordinate, the left and right side of the body, etc. There can be some inefficient movement that perpetuates when we're trying to reorient like that. So the individual joint assessments that we're going to get to here are looking to see, there's two parts to it. It's looking to see how the jointed area functions in an isolation of movement. So flexion, extension, or adduction, abduction. And then we're also going to look and see if the antagonist function is appropriate and allowing for that movement. And then we also can apply an external force to challenge that, to muscle testing, functional testing, to see if the action can sustain with a small load, not heavy just a little bit of a challenge to it. Okay. Here's some general guidelines. And you're going to want to slow down and process. This will help you with the critical thinking process. And then we're going to get into the areas by region. So the name of the movement, the muscles involved, the range of motion that would occur with active or passive joint movement. And one way we can position the client so we can isolate these movements, and then we can do some sort of a muscle challenge assessment, a muscle testing assessment if we want to. The textbook is set up so the agonist-antagonist patterns are adjacent to each other. This will become more clear when I show you an example. So these show up in a regional area. Stop and read your practical application. So we're going to have a general narrative overview of the area, which will include everything we've had so far, all of the anatomy, physiology concepts so far, specifically focusing on the relationship of the bones, joints, and muscles. When you read these narratives here, you should be able to understand what they're talking about. If you don't, then you need to go back and identify where you are confused and see if in the previous chapters you can find the content that will bring some clarity here. So this can also become an area of self-testing. So we have got the trunk and thorax, we got the spinal or visceral movements. We've got some visuals here to help. And then, this is a review and integration segment. Then what we'll do is this set up as an activity. But you can incorporate these movements into the massage session as part of the active and passive joint movement. The blue arrow is helping you decide how you're going to position. And then the red arrow gives you an idea if you're going to do a muscle test, in what direction your resistance would be applied. So the first pattern we've got here is trunk extension, and it will pair right up with trunk flexion. So you've got a picture to look at here. It gives you all of the muscles that are involved. So these are all of the agonists, all the prime movers that are used for trunk extension. This is what picture looks like, trunk extension. Now, some of these are going to be more stabilizers. Some of them are going to be more like fixators. Some of them are going to be helpers, and they're going to be synergists. So if I put myself in this position, I can do this standing up. There's going to be activity of some type in this group of muscles to produce that movement. Now, that creates a cave. And on the opposite side, we're going to start having a hill. So all of the muscles on the opposite side of that movement are going to have to be in an eccentric function. Gives you an idea of what the range of motion is. There isn't any in the thoracic spine, but up to 25 degrees from anatomical position. And there was a space up here that kind of helped you, this right here, kind of gave you an idea of how you would eyeball those ranges of motion. There is a tool that can be used called a goniometer. physical therapists will use that quite often to get a real precise range of motion measurement. Okay. Adjacent is going to be the opposite movement. So if I am doing trunk extension, then my eccentric actions are happening with the trunk flexors. But if I move into trunk flexion, then the actions flip. So these are the muscles that produce trunk flexion. That means that the agonist-antagonist pair are the muscles of trunk flexion and trunk extension. So a lot of times, if a person can't produce a movement, it isn't because the muscles aren't strong enough. It's because the eccentric pattern, for some reason, isn't going to let go. And so I would not necessarily look at my prime movers here. I would want to go and see what's happening with the antagonist group. So we need to see things in functional units, agonist-antagonist interaction. Same here with this trunk flexion. Here's the cave. These are shortening, but there would be a problem trying to get that range if the muscles of trunk extension didn't let go and function appropriately in their eccentric action. And then we go on further and we've got trunk rotation and elevation, and then we get into the neck. So we've got capital. Capital means the movement of the head at the atlas and axis right there at the top. And so these are the muscles that produce extension. That's tipping the chin up. This is how much you expect from the movement based on the joint function. I have my little guy here. All right, so capital extension would happen here. It would be this action. So from anatomical position, we're going to measure that, and it should be about 25 degrees. That's all. Okay. Here is this position happens to be with the person prone and they're just tipping their chin up, and there's your extension there, capital extension. And then here's the opposing movement. Here's capital flexion. Capital extension, bringing it back to anatomical position, and then forward into capital flexion. All right. So here are our this functional unit. Here's the extension. Here's the flexion. Here are the muscles that do that. So here is your agonist antagonist group, depending on what action is occurring. Now we're going to bring in the whole cervical area. This is cervical extension. And then this is cervical flexion. And then the relationship of the muscles to each other is a functional muscle group. These have to work together. So if a person is unable to easily flex their whole cervical area forward, then we have to decide, are the cervical flexors not strong enough to pull the head up and flex the cervical area, or are the cervical extensors not letting go? not functioning appropriately eccentrically. And there's a battle going back and forth here. I'm going to tell you that a lot of the time it is problems in the eccentric function. They don't let go. And so that is going to interfere with the actual trying to produce a movement. And again, as you visualize this, you're going to want to pay attention that when muscles contract, shorten in their eccentric or concentric function and pull, they're going to create a cave, and that should result in a hill on the opposite side. So this goes into the rotation, and then we get into our abdominal region, shoulder region, glenohumeral, down through, talks about all the movements. So you will want to study the shoulder region now as a unit. Just like we did the trunk and the cervical area. And the scapula, movement of the scapula becomes part of that. And then here are the shoulder girdle muscles. You should be able to, when you read this, you should be able to understand it. If you don't understand what the narrative is saying, you need to slow down and see where you're starting to get confused, and then decide, do I not know the names of the muscles? Do I not understand the direction? Where is my vocabulary not sufficient? Or am I getting confused over relationships? And then here is that same activity set up. So there's a lot of movement here first with the scapula. They're set up in opposing muscle functions. And this just keeps going all the way through. And it is a really nice way of practicing active and passive joint movement. These positions are a setup for performing various massage applications. They certainly are assessment. And we want to integrate this and the understanding of this into the general massage. It becomes part of the general massage. And then using that as assessment, if you find where the balance isn't the best, then you can try to find an intervention, work in the area that's short, try to get it a little longer, activate the area that's long. Short is in the cave, long is over the hill. And see if you can get the nervous system to understand what each group of muscles is supposed to do. They may have to do some therapeutic exercise that a physical therapist would coordinate if they're recovering from a trauma, for example. So here we go, just continuing on. And now we're into the hip. Here's your narrative. So remember, the blue arrow is telling you how to position it, and the red arrow is telling you how to push it out of that position for a muscle test. Here are all the muscles that are involved in hip flexion. If you can't remember what this muscle is, you can copy it and put it into the search program. It'll take you at some point back to chapter 9. You can review that a little bit, review that again in order to help you understand. Here's a picture of it. So bringing the leg up into hip flexion is how you position it. And then if you want to do a muscle test, you come down at the distal end of the joint, remember mechanical advantage, and with a light pressure, you challenge, you ask the structures to hold, to function. Now, there are many ways. Some of these you see the person is seated, some of them they're laying on their back, sometimes they're laying on their side. The other challenge I would give you is, what's another way? What would this look like? This hip external rotation, because you follow the knee, not the foot, you follow the knee. What would this look like if the person was laying on their back? Or what would this look like if the person was laying on their stomach? Position them that way and see what that looks like. Here's the joint. Various movements of the knee, the ankle and foot region. And then your activities. So this, if you're struggling to understand the narrative, as I've said before, then you need to go back and review concepts and terminology so that this feels clear to you. And then these activities bring it into really practical application. They're set up in functional muscle groups. So here's knee extension. The very next one will be knee flexion. I misspoke there. This is knee flexion, knee extension, the interaction between the two muscle groups. And then we get into the same thing with the feet. So this chapter is something that you're going to want to think of it as an integration. All of the pieces come together here in this chapter for you. And these activities and this understanding becomes a very important part of your critical thinking. And how you answer a multiple choice question is critical thinking. How you write a treatment plan, how you discuss something with somebody else, how do you explain something to the client, is a critical thinking process. So here's your pathology. And the pathologies here are going to be more movement related. They're not going to necessarily be a name of a condition or a disease. So one theory on disruption here is called the upper and lower crossed syndrome. These are theories. This is based on caves and hills. And the postural deviations that we will see during our visual assessments. So this gives you guidance on how to do that. Then we can get into a more regional. This is more of a whole body idea. Down here, it gets more regional. And then we also can have neuromuscular related, where there's a problem with the nervous system. And then we also have myofascial, and usually it's all combined together. So the joint related dysfunction, this gives you guidance on what can set that up and indications and contraindications. This is the STAR is a sensitivity to palpation, tissue texture, asymmetry, restricted movement. This is a classical approach to assessing an area. the musculoskeletal dysfunction, unless there is an injury, the biomechanics of it is usually progressive. So this is going to describe the progression, first degree, second degree, and third degree. Generally, if a person is just beginning in these stages of dysfunction, first degree, massage therapy can be an important part of kind of sorting that out and getting back to optimal function. But when it starts to move into second degree and third degree, then it's going to be a more complex interaction. So this is the distorted motor function. This, for example, in a first degree, they start using their synergists more than just for a helping process. They actually are using synergists as the prime mover. They're the second degree, they're bringing in other parts of the body for stabilization, for example. And then in third degree, you're actually seeing postural and movement distortions. It's obvious for us to identify. And then how this leads into the various dysfunctional areas and when it's appropriate for us to intervene autonomously, when we need to refer and learn to work with other professionals that are part of helping that person achieve optimal function. I learned this a long time ago from a wonderful teacher named Dr. David Girovich. He actually was from Russia, and he immigrated here to the United States actually as a refugee and spent about 8 years at the school, and I learned an awful lot from that gentleman. Okay, what I had just been telling you, how the textbook content translates into practical application, that's what this box is. So pay attention to this box, because it'll take you all the way through how this information coalesces to be used in a massage therapy application. Then we have our indications and contraindications. So here's your section summary, the summary of the chapter. And we've got a couple of other assessments here. We've got a protocol for gait muscle testing, and how, when we were talking about gait, how we were describing how opposite arms and legs are coordinated for counterbalance. And the videos that go along with your fundamentals textbook, the fundamentals textbook, also has this content. And Luke and I have also posted additional videos about this on our YouTube channel for the school. Can help you have a visual on this. Again, this is not likely to be tested on the MBLEX exam. Okay, there you go. And we are going to stop the share. So I can remind you to go to your online course, the orange one, and compare and contrast the information there in the biomechanics module with what you've got in the chapter. And then there's a lot of crossover here now in chapter 10 with the similar chapter structure in fundamentals. And so you're going to want to have both books open so that you can expand and see, okay, here is how it's described in terms of massage theory and application, and here's how it's described more in an anatomical, physiological process. So this chapter is a bridge chapter as well. Okay, very good chapter, this chapter. All right. Now, this completes our unit 3. And the last unit, unit 4, are those 2 chapters that cover the rest of the body systems. And they're already pre-consolidated to target information that's most relevant for massage. Look at the videos.